Okay, well, hi everyone, and welcome to our November STEM Talk. So this month, our STEM Talks is focused on respiratory health, and we have three very exciting panelists joining us today. Before we get into that, I'm just going to launch a little Zoom poll that kind of checks in with you for today's event. So that was launched, and you should see a little pop-up on your screen, and I'm going to get started with our housekeeping. So if you've never been here before, we usually have three panelists. So we have today a radiation therapist, a respiratory therapist, and a lung transplant researcher. They're each going to present their slides and share about their education and career journeys. And then we're going to have our Q&A session. If you have any questions, please put them in the chat and we will get to them during the Q&A. And if you are here for our certificate program, our certificate program uses Zoom to track participation. So as long as you have your first and last name on your Zoom name as the same name that you signed up for the program for, we will be able to track your attendance today. And if you haven't heard of this program before, this is our monthly program where you to attend 7 certificate eligible events like our monthly STEM Talks will be able to get a certificate of participation signed by senior UHN leadership. As well, you can also receive a health and wellness SHISM certificate if you are in the SHISM program for either medical terminology or lab practices. So after we start the event, I'll put this link at the bottom in the chat, but here's a little preview of some of our other STEM Talks this year. So I'm going to see how our poll is doing. I see a lot of interest in lungs and respiratory health, and quite a few of you have been here before. So I am going to stop the poll and pass it on to our first speaker today. So Grace, that will be you.
Everyone see my presentations?
Yes, looks good.
Okay, so just a brief introduction of myself. My name is Grace, and I'm a radiation therapist in Princess Margaret Cancer Center in the radiation medicine program. And my focus is actually doing radiation to the lung site. And I'm a site lead of that area in radiation therapy. So a bit of a background. I was born in Hong Kong and I came to Toronto in grade 7. So I've been working in the Princess Margaret Cancer for 18 years. I'm currently living with my husband and our cat child. One of my hobby is to dress him up. Even though if it's not Halloween, we still like to dress him up occasionally. It's just one of our stress relieving hobbies that we like to do. But then I also pick up another hobby since COVID, and I started learning cello. So that has become my new hobby since then. Okay, so I graduated from University of Toronto, and I have a Bachelor of Honors in physiology. And then I entered into the medical radiation science program, which is a joint Bachelor of Science and a diploma program between U of T and also Michelin Institute. So just a brief explanation of what radiation therapy is. I get people ask me a lot of questions what radiation therapy is. It is definitely not what we're doing for X-ray pictures. We actually use radiations to treat cancer, which involve really high energy of radiations to focus in the cancer cells and damage their DNA, and that's how we kill cancer with radiations. And oftentimes this radiation is 100 times stronger than the X-ray that we use to take the X-ray pictures. So what do we do with radiation therapy in lung cancer? So a lot of time it's a combined treatment with chemotherapy or surgery. So we use radiation therapy to achieve just to help to control the cancer and also to cure the cancer. So that's the major intent, but then we also use radiation therapy to treat some of the emergencies. Sometimes cancer gets like really bulky and then it takes over the airway, or sometimes it actually eats into the bone vertebrae which is the spine, and then the spine collapses and it's pressing onto the nerves. Then in those cases, we also use radiation therapy just to hopefully to manage the symptoms. And then there are also situations where we have metastases, what we call, i.e. the cancer spreading outside of the original body site. Sometimes it can be a prostate cancer, but we have a spread to lung. Then we also use radiations to treat those little metastases. Okay, I have a video that shows exactly what radiation therapist life is. Let me see if I can just play it. And then I need to share a computer sound. Yeah.
One of the faces you will meet here is a radiation therapist, a frontline staff who delivers radiation therapy to patients. Our three major tasks are scanning, treatment planning, and treatment delivery. Before patients start radiation treatment, they need a CT scan. A radiation therapist scans the patient in a position that can be easily repeated for treatment. Depending on the area being treated, patients may need custom immobilization devices. After the scan, patients get permanent tattoos. Each one looks like a little blue freckle. We also work together with radiation oncologists and medical physicists to create a treatment plan for each patient based on their CT scan. Now the patient is ready to start their treatment. Radiation therapists set up the patient on the treatment machine. We also perform a cone beam CT or CBCT. This ensures the patient is in perfect position during treatment. As radiation therapists, we get to know our patients well. We provide advice on managing side effects and help our patients get through their treatment. Although we deliver radiation therapy, we promise we're not radioactive. We are here for you.
Okay, so that was the video. So that's just a brief discussions of what a radiation therapists do, and how it is like in the life of radiation therapist. So let me just go in more detail of what I actually do on top of what was described in the video. So as a site leader for lung radiation therapy, I also do quality assurance. Each week we will be talking about each lung cancer patient treatment that comes through to our department, and then we'll be discussing and reviewing their cases with oncologists, with physicists. We'll talk about the quality of their treatment plans, and then we also talk about their management of their treatment plans. So that's a part of quality assurance. And then I also do educations on lung radiation therapy, especially planning, where you see a computer earlier, having a lot of like CT images, a lot of lines in those plans. So that's what I do. I explain to visitors and multidisciplinary within the UHN, and my peers, the student, on how to come up with a treatment plan for radiation therapy to the lung site. And also as a teaching hospital in Princess Margaret Cancer Center, we carry out a lot of clinical trials. So we do have a lot of clinical trials that is pertaining to the lung radiation therapy within the department, and my responsibility is to help implement these trials in our clinical areas. And then lastly, I also oversee and update all the department protocol, making sure that it's adhering to the current practices of radiation therapy. Just a bit of descriptions of why I think it's important in my job. So according to the Stats Canada 2021, cancer is still the leading cause of death in Canada. And then according to the stats, 2 in 5 Canadians will be diagnosed with cancer in their lifetime. So cancer is a major thing in our lifetime, actually in our life. I'm pretty sure Some of you may have come across someone that you know, maybe it may be a family member, maybe a friend, family, friends that is diagnosed with cancer. Or affected by someone in their family having cancer. So that's a major interest as I was growing up, because I came across cancer when I was in university. One of my very close family friend passed away from cancer. So it really sits in my heart personally also, on top of the stats that we were going through, we have from the statistics. So the reasons for choosing this career is that to me personally, I get to the opportunities to touch someone's life, even for the very brief moments in their lifetime or in the journey in conquering cancer. It may be 5 minutes, it may be 10 minutes, but just having that opportunity, that moment, it's amazing. It's very meaningful to myself. So that's one of the major reasons that I chose this career. Second of all, I get to interact with people. I get to meet a lot of people throughout my career. Sometimes I was able to encourage them, but a lot of time is actually encouraged by patients or family who are going through their cancer treatment. It's really amazing just to have that interactions. I get to learn a lot from the people that I interact with. Also, because of my career, I get to share a lot more knowledge about oncology, cancer, with my family or friends. Sometimes they come to ask me about questions about cancers, or especially about radiation therapy treatment. So I enjoyed that part of sharing knowledge with people that I know. And then also that I don't have to do overnight shifts, unlike nursing. So I get to sleep at night. I don't have to stay up overnight and work. That's a major plus when I was thinking of career when I was in university. And then just when I was in university or high school, I know that I was good in mathematics. I love science, especially physiology. So which I was able to fulfill this love in this career. And then I get to learn a lot more about radiation physics. And also just to, especially with this position, it really motivates myself to continue educate myself with the latest advances and the practices in radiation therapy in lung cancer.
Thank you, Grace. So I'm just going to spotlight Jennifer.
Can you see my screen?
Yeah.
Okay, great. Hello, that was great to hear about Grace. I learned a lot, actually. I work with radiation therapists and didn't know all that stuff. So my name is Jennifer. I'm a registered respiratory therapist. I'm actually the charge therapist at one of the University Health Network sites at the Toronto Western Hospital. We also have RTs that work at Princess Margaret and at our Toronto rehab sites as well. So we're kind of working everywhere across UHN. A little bit about me. I'm not from Toronto. I'm from a small town in Eastern Ontario. So grew up in the small town life. And when I had to choose a university, I decided to go completely in the other direction and choose a big city. I moved to Toronto for my undergraduate degree. Did all my schooling in Toronto, got a job here, and I haven't quite left yet somehow. I've been working as an RT at UHN, so at the Toronto Western site, for 15 years now. And I've been in the charge respiratory therapist role for the past 8 years. Outside of work, I am a pretty active person. I do play a lot of sports and activities, played in a lot of basketball leagues up until COVID. I downhill ski quite a bit, softball, I'm on a dragon boat team, and just recently joined the trend with everybody else and have started playing pickleball. I also quite love traveling. A lot of my extended family is in PEI, so that's one of my favorite places to travel. I've climbed Kilimanjaro as well, so lots of travel in my spare time. So for my background to become a respiratory therapist, first touch on my education. So as I mentioned, I came to Toronto for my undergraduate degree. I did go to the University of Toronto. I did a double major in biology and bioethics, which was actually a really neat pairing to get both sides of it. After my undergraduate degree, I went to the Michener Institute and did a diploma in respiratory therapy. So that was a 3-year program there, and started working. Ever since I've been in the charge therapist role, I've also continued my education. It never ends. And I, a year ago, got my Master's of Health Sciences through Athabasca University. Not required to be an RT, but something I've done since. So just on the topic of respiratory therapy and what is a respiratory therapist, and hopefully some of this is a little bit more known since COVID. Certainly before COVID, I think respiratory therapy was flying a little under the radar, and good or bad, we've gotten a little bit more press since COVID. So a respiratory therapist is a registered professional in the healthcare system. We work all across Canada, so in all provinces and territories across Canada. And we're trained, to stereotype or to look at the bulk of it, we're trained in ventilation and airway management, including cardiopulmonary resuscitation and oxygen and aerosol therapy. So we're really trained to monitor, assess, and treat. So kind of all aspects of helping people breathe better. We treat issues such as asthma, COPD, which is chronic obstructive pulmonary disease, pneumonias, just like COVID, and heart disease and the effects that heart disease can have on our lungs. We care for patients during outpatient procedures such as pulmonary function testing, cardiac testing, during surgeries, after surgeries. We're there in labor and delivery and high-risk births, and also at the other end of the spectrum in rehabilitation. Just wanted to mention kind of the requirements to be an RT, as I touched on earlier. So it does require the completion of a 3-year diploma program. In general, it's a 2 years in classroom didactic, a lot of simulation, and then 1 year of clinical placements in hospitals. It's offered at several schools across Ontario, Michener being one, but at several other schools. And then it does require passing a national licensing exam to be able to call yourself an RRT and work in the province. So day in the life of a hospital RT is a little bit hard to describe because the day can be really different. We're in hospitals and we're needed 24/7. So Grace mentioned she doesn't have to do overnight shifts, and I'm very jealous, but RTs do have to do overnight shifts. So in general, we are doing shift work very similar to nursing, usually typically 12-hour shifts, so a 7 to 7 type of shift, on days, on nights, on weekends, and on holidays. So we are 24 hours a day. Like I mentioned, no 2 days are the same, and it can really depend what area of the hospital that you're covering. So you will find RTs a lot in intensive care units. That's where the bulk of our work would be, but we also cover and care for patients on inpatient units, in the emergency department, in the operating room, including labor and delivery, like I mentioned, and in outpatient clinics. So in general, we are responsible for managing the mechanical ventilator, so making all the changes on the ventilator to the patient's needs. We are responsible for oxygen therapy, for humidity therapy, for patients who have a tracheostomy, which is an artificial airway in their neck. We would be responsible for managing that airway, making sure it's clean and patent. Airway management at cardiac arrest, so code blues. We do diagnostic testing, so pulmonary function testing, where we get patients to take big breaths in and exhale, and we measure how big their lungs and their lung capacity is. We are involved in rehabilitation, getting patients ready to go home, who have experienced an admission at the hospital, who are going home with a new lung disease. Perhaps they're going home with oxygen. So getting them ready for that. There's a lot of patient and family education, and we're involved as well with the discharge planning. Just wanted to mention as well, there's a few other specialty areas that RTs are involved in. Something called an anesthesia assistant, so working exclusively in the OR, helping the physicians that manage the anesthesia and manage patients while they're having surgery, is a specialty area you can get into after you become an RT. Home care is a whole other area, obviously outside of the hospital, that I don't work in, but it's a very important area, so that we can get patients home and back to their families, even if they need oxygen or have a trach or require a ventilator. So lots of RTs are working in home care as well. We also work in sleep therapy clinics. So perhaps you know someone or have a family member who has obstructive sleep apnea, snores a lot at night, goes apneic at night, and requires a CPAP or BiPAP device. So there's RTs are working in those sleep clinics to help do the testing, to help prescribe and adjust the CPAP and BiPAP units and the masks needed. A fairly new role for RT is to be involved in some family health teams and with family physicians in primary care, helping to do a lot of education, some diagnostic testing in those areas. And for those RTs who really love education, there's also an additional designation as a certified respiratory educator. So doing even more education with patients and their families, if they're affected by COPD or asthma, how to take their puffers properly, what to do when they get sick, if they want to quit smoking, how they can do that. How they can, clear the secretions out of their lungs. So a lot of education in that area. So just wanted to finish with the importance of the job and why I chose the career. So I think hopefully in the last 3 years, we've showed how important RTs are in the interprofessional team throughout various areas of healthcare in the province and the country. We really play an integral role in helping patients breathing and getting them back home. The best thing I love about RT and why I chose RT myself is that we do get to be involved in the care for patients along the entire continuum of care. So as I mentioned, in some of the areas we cover, we can be involved right from birth, right all the way, to helping someone have a peaceful and painless death. We get to be involved in all of it, sometimes in the same day. We're involved in both, kind of reactive medicine, but also in preventative medicine. We are very skilled clinicians, needing to look at the whole patient, but we also have a real expert level of technical knowledge. So for those folks who like working with patients, but also like working with machines and making sure they're running, RT is a really good mix of both the technical and the clinician side of things. We don't have to choose a specific area to work. We kind of get to work in them all. And that's a really great way for people who, want to experience all different parts of the hospital. We're a very social group, very active in team environments because we're going to all these different places. We're on our feet all day. We're working in teams and in all different areas of the hospital. So it's really good for people who like to be social and like to be part of the teams. As far as job prospects in RT, unfortunately, the pandemic has made us even more important, which means the job prospects are really quite good. RT in general is a fairly new profession. It's approximately in Canada, it's only been around for about 60 years. And it was a bit of a slow climb getting into the hospitals and now has kind of taken off. So it's still a growing profession when we compare it to other healthcare professions. Because of that, there's a lot of job prospects as new areas try to expand and they're creating new positions elsewhere, as well as with every profession in healthcare. And I'm sure my two co-panelists would agree, our aging population in Ontario and in Canada is leading to lots of new positions in healthcare, and that goes for RT as well. in addition to the long-term effects specifically to breathing that the pandemic has had, and because of the backlog to medical procedures and ORs and the busyness that's created, very good job prospects for RTs.
Thank you, Jennifer. So we have our third and final panelist, Faye, is going to present next.
My name is Faye. I am currently a master's student in the Institute of Medical Science at the University of Toronto, and I'm currently researching at the Princess Margaret Cancer Research Tower, which is also part of Toronto General Hospital. So a little bit about myself. I was born in Henan, China, and I moved to Toronto for my kindergarten. I've been doing my research at UHN for 5 years, starting as a STEM student during my undergraduate. And a little bit of hobbies. I enjoy playing water polo, and I also picked up Formula 1 and motorsports recently. And here you see on the left, this was moments before my goal versus McMaster University, as when I was playing on the Western varsity team. And middle, this was from the IndyCar race in Toronto this summer, and somebody got a signed tire from one of the racing drivers, and I got a picture of that. And on the right, I went to Belgium to watch the Formula 1 race, and this picture was from the podium after the race. So about my education, I did my undergraduate degree in physiology and pharmacology at Western University. And from that, I decided to continue to do research with U of T, with the Institute of Medical Science, which is what I'm doing right now. And a little bit about what I do for my research. So my lab is particularly focused on this technique, the ex vivo lung perfusion, which we shortened to EVLP. And this technique was actually invented here in UHN. So with this, what happens is that a donated lung can be tricked into thinking that it's inside the body, but in actuality is sitting outside of a human body. And from this image, we can see that we place the donor lung into this kind of dome here, and we attach tubing, which a pump applies like a perfusate or a fluid that resembles blood and carries oxygen into the lungs and out of the lungs, as would in a regular human body. And we also have a ventilator that provides air to the lungs, and the lungs are actually inflating and deflating, and you can see that with your eyes. And so this technique allows us to assess the functions of a lung before transplantation, and also allows us to provide treatment to lungs to repair any injuries. So for my project, I'm working with the Lateral Thoracic Research Lab, which is a collaboration between many supervisors, and it's a huge group. And we're all focused on doing research in lungs. So for me, I'm looking at strategies to extend the duration of this EVLP, because if we're able to preserve the lungs outside of the human body for a longer period of time, then that allows for many different opportunities. It allows for us to do even more complicated and more time-consuming interventions during this time. And also, it allows for better logistics of lung transplantation, because sometimes when you have a donor lung, it might be late in the day or maybe at night, and then the lung transplant would have to occur overnight. And as Grace and Jennifer said, that nobody wants to work overnight. And for lung transplant, also, you expect that the quality of the transplant would be better if the staff wasn't sleep deprived. So this results, this improvement and the prolonging EVLP would result in more lungs that would be suitable for transplantation. And just a little bit about a week in my life. So I would conduct an EVLP experiment, which may take up the whole day if I'm looking at prolonged perfusion. and I would be processing the data that I would receive from that experiment. But also these EVLP experiments aren't a one person job. It requires an entire team for like the surgery and also for the perfusion. So I'll also be helping out other lab members with their experiments as well. Then we have to attend the research in progress meetings for the entire Latner lab. Each week, one member will present their research, and we get to hear about the new stuff that they're working on. Then for our own personal smaller lab meetings, I can present and update the data that I have that I've been working on and get feedback from other lab members, and also listen in on other lab members' progress and also participate in that discussion as well. And then the rest of the week consists of reading up on current literature about EVLP, lung transplant, anything that pertains to my research project, and also a lot of writing sometimes, different proposals, submitting things for conferences and whatnot. And of course, since I'm a student, I also have some classes to attend, as well as a journal club where we all read a particular article and then talk about it afterwards in a group. So why is research in lung so important? Well, lung transplantation is the only treatment for end-stage lung disease right now. And here we see that the trend over the past few years is that more and more people are requiring lung transplant and are being put on the wait list. And in the red bar, we can see that there are still people dying while waiting for a lung transplantation. And one of the problems that we see is that out of all the organ donors, solid organ transplant, the utilization rate of lungs is very low at 20%. Only 20% of lungs being donated are suitable for transplantation, with the rest of them being potential for various reasons of like injury and whatnot. And so they're not suitable for transplantation. Well, I would like to use EVLP and other research methods. We want to increase this percentage and increase the number of lungs that are being utilized. So then we can shorten the wait list and then prevent any deaths while on the wait list. So then more people can have healthy lungs. Thank you very much, everybody.
Thank you, Faye. I'm just going to spotlight our panelists here. I almost forgot myself. Hey, there we go. Well, thank you, everyone. I think I should mention today after Faye's presentation that today is the 40-year anniversary of the first ever lung transplant done in the world, and it was done at UHN. So very fitting day to have this panel. So with that said, I see quite a few questions in the chat, but maybe we'll start it off with a more general question. So someone was asking, what is so captivating about your field and what got you into your field? And I know you kind of addressed it, but maybe you can each say one by one, like the inspiring thing that led you here. Maybe we'll go in order. So Grace, did you want to go first?
Sure. So what's still inspiring me is the advancement that we came along from in the last like 5-10 years in radiation therapy. And then also also just honestly the interactions with patients. You get to meet a lot of different people and in their different life journeys. So it's very inspiring.
Thank you. And what about you, Jennifer?
So to get inspired into becoming an RT, I don't have a good story because I didn't actually know what RT was until I spoke to a cousin of mine who's in Saskatchewan, who's an RT as well. But what keeps me inspired at work really is, you know, we see patients at their absolute worst, like the sickest day and the sickest things, RTs are involved. And that's not fun and that's not nice to see with, you know, with the families. But then a couple weeks later, when they get better and we're also seeing them on the floors and they're better and they're awake and they're talking to their family and we get to take the trach tube out and we get to give them their voice back and they get to eat again. So just being able to kind of see the difference and see those patients and the journey they make does really inspire me. I have to say too, people like the research that we just heard about really inspires me, because I can't wait to be working in healthcare when some of these developments, get out to the patients that I'm working with, and I'm going to get to see patients benefit from lung transplants who would have died before. So I'm also inspired by the work of, my colleagues as well.
Yeah, and what inspired me to do research was when I did my undergraduate degree, I was in an honors program, so we had a thesis component in our final year of study. And for that, we were doing real world research. So we found a research lab and worked towards writing a paper and doing a poster presentation. And that was something completely different from every other class that we had, because every other class, you get taught information. But in this case, you're the one finding out the information yourself, that none of this exists previously. You're pioneering your own little project. So after that experience, I found it was so much more fun than just learning and memorizing information. So I continued to do research from then on.
I think three very different yet similar answers, all very inspiring. I see a very specific chat question, so maybe Grace, this one is for you. They're just asking what a CT scan is, and someone answered, but maybe you can specify a little more what the difference between a CT scan is versus like an MRI or an X-ray.
I'll try my best. So CT scan is it's okay. Let me start with X-ray first. X-ray is to use X-ray energy, radiation energy, to take like a snapshot of a picture. So it's like a single picture. So CT is a snapshot of many pictures of these. So we call it computer tomography. So it's like it's many X-ray picture that comes together and then generate a 3D images of the patients. And then MRI is a little different because we do not use radiation therapy. We do not use radiation to do MRI. We use magnetic field changes to detect the differences of patients' tissues. In short, so that is the very brief differences between X-ray, CT, and MRI.
I think that was a great summary. I just want to quickly squeeze in. I see some worries about radiation from the phone versus radiation when you're in the hospital. Maybe can you touch upon like the risks or the safety features in place?
So I'm not quite sure about this radiations from the phone, but radiation is actually very common. We actually have a background radiations too. So even though we don't do anything, even though we don't have anything around, we still have a background of radiations, which is very minimal. Every patient, or not everyone, has like a tolerance to certain radiation, certain amount of radiations. So with radiation therapy, as we said, we use very high energy of radiation. So radiation is very focused, so it really beams to the area that we like aiming at. But of course, with high radiations, we also, as therapists, we do have a lot of safety measures because, as I said, we use high radiations to the way that we treat cancer cells is to use high radiations to damage the DNA of the cells. So as you can imagine, so radiation has the capability of damaging DNA. So as a result, we do have safety measures as we work in the radiations. We have, first of all, each of us will wear a radiation monitor. So it will just keep track of how much radiations we have encountered. And then for each radiation therapy treatment unit, we have very thick lead wall to prevent radiations. We also have the way that we design the radiation room. We have like a maze, so you have to go through like like a hallway in order to go into the treatment machine. That's also a way of minimizing the radiations. So when the radiation's on for the patient, when we actually beam on, we actually the patient will be in the room by himself or herself. The rest of us, staff, family, will have to leave the room. And so that's just a measure for us to ensure that no unnecessary high energy of radiation is getting to anyone.
Thank you. I think that covered it. So for the most part, you really don't have to worry about your phones, and radiation therapists take a lot of special precautions to make sure they're keeping patients safe. I see a pre-submitted question, and this is maybe more for Jennifer, and it was asking about how COVID-19 and the pandemic impacted your field.
Yeah, we might not actually fully know how it impacted our field for a while yet. I think there's two different ways to look at it. I think COVID has impacted our field just like it's impacted everyone in healthcare. It's a really, really stressful time. There's a lot of burnout from that, a lot of things we had to do that weren't great, as far as having to stop surgeries so that we could keep beds open for COVID. And that doesn't feel really nice to have to cancel surgeries for people who need it. So there's kind of that mental, ethical stuff that is going to impact it. I think if we're looking at perhaps some of the good that COVID has impacted RT specifically from the clinical side is it's really made us think a lot about our PPE. And what we need to be wearing and making sure that we're staying safe. So we're so much better at wearing PPE, putting it on, in what situations we have to put it on and when we don't perhaps have to put it on. So I think from keeping staff and healthcare workers safe, we've gotten so much better at that thanks to the pandemic. And then also just looking at the therapies that we provide to these patients and looking at potential advancements in technology thanks to COVID. So, one thing COVID emphasized was we don't want to go in the room many, many, many times. We want to reduce how many people can go in the room. So is there technology now that may allow us to change settings on vents from outside of the room? So it's not here yet, but it's in the works. And I think the pandemic has helped advance some of those technology. And that's where that intersection of RT with the clinical and the equipment can be really exciting. We get to look at both sides.
A lot to look forward to. I see this longer question for Faye, and they're asking, how are lungs transported into that preservation state? Can that be used for hearts as well?
Yeah, so the lungs come from, well, unfortunately, in a clinical case, a patient must have had passed away because you would need your lungs to live. And if that patient consents or if their family consents for their organs to be donated, then we have a team of surgeons who go and retrieve the lungs from the patient. And then what we do is that we flush out the lungs with a preservation solution, and then it gets attached to the machine basically through the artery and the vein. And then we finish a circuit with a pump, and then the fluid can be flushed through. And the pump kind of acts as your heart, because in your human body, your heart acts like a pump that pushes your blood throughout your body. But here, and because we don't have a heart, we use a pump to do the same thing. Now, can we do the same thing with lungs? Well, yeah, absolutely. So actually, in this building, we have teams doing this ex vivo perfusion for pretty much every solid organ system. We got a team doing it for heart, liver, kidneys, pancreas. And so we all have our own team and all trying this technique to extend the perfusion and the preservation lengths. And actually, if anybody is interested in getting some firsthand experience with this, I started doing volunteering here when I was in high school. So if you're interested, don't hesitate to reach out to UHN or me, and I can maybe direct somebody to some of the teams that are working here if you're interested.
I think you kind of touched on the second part of their question, but they were asking, I guess you mentioned there's a pump for keeping the lung with EVLP, but they're asking, would you preserve the lung and the heart together at the same time? Or is there no need for that maybe?
Yeah, so for this kind of intervention, you would want to ideally do it separately, because then you can, because if you have, let's say, a donor that, and usually when we have EVLP, the organs are injured in an injured state. We don't want to be perfusing two injured organs together. That might create some issues. We want to do it separately and treat them separately.
Thank you. I think that answered that. And yes, like Faye mentioned, it's great to get involved by volunteering. So if you're interested, feel free to reach out to us and we can help you with that. I see a more general question. Maybe all of you can answer. What is the hardest part out of all of your careers? So maybe Grace, you can take that first.
I have to say is actually the struggle between the front line and the management. So hospital will have they run the hospital is run by funding. So and then there's like as a frontline therapist, you want to do so much more than what you can or allowed to do or budgeted to do. So there's always this struggle between what you want to do and also what you can do at the end. So that's I think that's the hardest part in my career.
I think for me, two things are, I'm thinking about my colleagues too, not just me, but for those of us in respiratory therapy. The two biggest things that I would say are the hardest is one, we're running in when everybody else wants to leave. So things like COVID, when everyone else wants to stay away from people with COVID, we have to go in. Things like Ebola, tuberculosis. So, these things where everyone tries to stay away, we have to go in and we try to make it as safe as possible, but that can be really hard to kind of be running in when everybody else wants to leave. The other thing that is typically the hardest when we first start to get into the profession is death. Unfortunately, we do see quite a bit of death. We're involved in end of life care. In the intensive care unit, we can often be the people who are, pulling the tube at the end of life. So that can be hard. That can be challenging. We have a lot of supports. We talk about it a lot. We're never alone. There's, a whole interprofessional team, but that can be something that's certainly perhaps the first time people have had to deal with that when they get into a profession and can be difficult.
Hey, what about you? You might be on mute.
Yes, well, one of the most difficult things about doing research is when you don't get the results that you want. Oftentimes, we don't know what we're expecting. We're trying to explore the unknown. So we make a prediction and we test for it. And hopefully it goes right, but there are so many unknowns and, unfortunately, that might not be the case. So you just got to keep trying. Revise your protocol, do some more reading, and then try again.
Thank you. And I see some questions from earlier about anesthesiology. I'm not sure if any of you can answer, but they're asking what's the difference between RT and anesthesiology. I'm not sure if RT is radiation or respiratory, but maybe Jennifer or Grace, you can take that.
Sure, yeah. So I presume the question is what's the difference between RT and an anesthesia assistant? Just because I mentioned that. So, and I think I saw something earlier in the chat. So anesthesia assistants can be nurses or RTs. So I think that was another question. So you can go into anesthesia assistant as a nurse as well. So if you're a nurse first, you can go into it, or if you're an RT first, you can go into it. So the difference is anesthesia assistants work exclusively in the OR. And so they would be helping the anesthetist. So if you haven't had surgery, anesthetist is the physician who is putting in the IV, they're going to put you to sleep, and they're basically keeping you alive while the surgeon is performing the surgery. So they're going to monitor all your vitals, they're going to give you the medications to keep you asleep, they're going to put the tube in. So the anesthesia assistants have a scope and a role to do some of those tasks. So, typically they might help put in the IVs, they might help intubate, perhaps once you're asleep, the anesthetist would go on to another case and the anesthesia assistant would stay in the room and make sure everything's stable. They're involved in some surgeries that are shorter. So maybe you just need a spinal block, similar to what women would get when they're going through labor, when they get an epidural. Anesthesia assistants might help a bit more with those. So kind of various tasks within the OR and within the anesthesia portfolio is what anesthesia assistants are doing. They are not physicians. So like I mentioned, it was a nurse or RTs that can go into it. So they're not full physicians. So the physicians have to be the ones giving like the narcotics and the medications, but they can help with various other tasks in the OR during a surgery.
Thank you. I think that was a good summary. And maybe to add on, that's more for the Canadian or the context in Ontario, but once you go into the States, it's a little different. So the scope of practice varies?
Yeah, so RT in general does vary in the States. So if you were looking to look in or to work in the States, it would be something you'd have to look into. They have RTs, but the scope of practice varies very widely at different hospitals, let alone different states. Whereas in Canada, it's pretty similar because we have a national licensing exam and a board. So our scope of practice is a little bit different in the different provinces, but is generally the same throughout the country. The same goes for anesthesia assistants. There's some differences throughout the provinces, but generally kind of the same across the country, but it would be very different in the States, yeah. And there's no RT outside of North America, just in case anyone is wondering or wants to start it up. There's a little tiny bit in Saudi Arabia, but RT as a profession doesn't exist anywhere outside of Canada. So in Europe, they don't have RTs or anything like that. Yeah.
That's really cool. I didn't know that. I see a question that's maybe more for Grace. Grace, you kind of talked about your education journey, but they're just asking, is there a specific undergrad required to be a radiation therapist?
So I think right now, last that I know of, I've been graduated for like so long already. For my professions are medical imaging, X-ray technologists. So we require 1 year of university, a regular 1 year university undergrad degree, experience before you can apply to the specific program available for missioner. So I think that's the basic prerequisite is 1 year university degree with like certain course that is prerequisite, if I remember it correctly. So yeah.
Thank you. And I think, Commissioner, the programs really vary. So there's some where you can direct entry from high school or some where you might have to do an undergrad or those courses like Grace mentioned. I see a more general question. How do you manage to stay healthy while treating your patients? Jennifer, do you want to start?
Sure. I feel like I have to take that one of two ways. One is, very literally, how do we keep safe? It is about the PPE, which, as I mentioned before, has gotten a lot better. So we're all fit tested for N95s as RTs, and we wear that for a lot of patients that we see. It depends on why they were admitted and what disease they might have. But if they're under isolation, we would wear N95s for quite a few patients and quite a few of the procedures that we do. In the hospital, we're still wearing masks with any patient interaction and eye protection. So we still wear that. And then for some procedures, we have to go a step further and we're wearing gowns and we're wearing caps and gloves and all that kind of stuff. So, but very high usage for our profession with N95. So we do that a lot. Non-literally taking care of ourselves because it is shift work. It definitely can mess a little bit with your circadian rhythm and stuff like that. So it's really important to sleep as much as you can, eating healthy, staying active, and really finding a place. It can be a stressful job. It can be busy. As I mentioned, we're dealing with death. So finding those ways outside of work for the self-care, for being able to get those frustrations out is really important for, I imagine, all three of us. But yeah.
Some great advice. What about you, Grace?
Basically, we did pretty much also what Jennifer do. We do also make sure that we do all the hand hygienes and all the basic like healthcare professional do for before seeing patients, after seeing patients, masks, face shields, gowns if needed. So that's the physical part of it. The mental part of it, because we also see many cancer patients, they have a lot of their life stories. So a lot of time you actually absorb a lot of these stories. It may be quite traumatic sometimes to hear all these stories. So sometimes we just have to like really be focused on why we go, like the reason of doing what we're doing, and the reason that we're going into this professions. And as Jennifer said, sometimes we just need to find ways to unwind at the end of the day.
Thank you. And Faye, I know you're responding to a question in the chat, and you don't really take care of patients, but I know working with donor lungs or healthcare workers, are there any precautions that you take or anything that you would advise?
Yeah, well, we also participate in proper PPE, and since a lot of our experience involves doing a donor surgery, we got to put on the full gown, mask, and glove protection. Although yes, we don't work with patients, we do animal research, and these animals that we work with are healthy animals, so they don't have any diseases or anything like that.
Thank you. And I know we're running out of time, so maybe one general question before we go for all our panelists. If you had to offer our high school students and attendees one piece of advice, what would your piece of advice be? Grace, do you want to go first?
I think my advice is just really pursue what you really enjoy studying, and that will bring you further than anything else.
I guess my advice along the same lines would just really to be embrace learning and education. Take your time, investigate everything, learn about all the different healthcare fields. There's so many out there that we don't know. Like I said, I didn't even know about RT till I was starting my 4th year undergrad. I'm so lucky I found it, but there's just so many different fields in healthcare. So take the time, educate, research, and then if you get into the field of healthcare, it is going to be continuous education for your whole career. So love learning, embrace learning, learn how you learn best, and I think that will lead to your success.
Sorry, could you repeat the question? I was answering something.
Bro, your one piece of advice for our high school students.
Yeah, I think what you should do is just pursue something that you enjoy, because I personally didn't realize that I liked research until the very last year of my university undergraduate degree. So, sometimes life just takes you wherever.
Thank you. Well, we're kind of out of time, so I'm going to slowly start our housekeeping and wrap up. So I'm just going to launch our wrap up poll while I talk. Ooh, it looks like it's been disabled, but let me share my screen here. So I want to thank our 3 panelists for being here with us today. I know we didn't get to all of the questions, but if you had any questions that you didn't get to ask our 3 panelists, you can email us at stempathways@uhn.ca, and we will pass your questions on to them. If you want to learn more about our programs, you can scan the QR code here or go to our website. We're also active on Twitter or X if anyone uses that.